Hello and welcome to my Opthal teacher. And today we're going to talk about anatomy, and subsequent lecture we're going to talk about the physiology of extraocular movements. And this is very important as it forms the basis for understanding strabismus. So, first of all, there are two main axes of the eyeball, the visual axis and the orbital axis. And normally the two eyes are aligned with each other such that the visual axes are meeting at the point of fixation. Now, suppose this is an object that we are fixing at, for example, a torchlight. So, a line joining the object of fixation, that is the torch, and the fovea, that is the point of fixation, is known as the visual axis. Fovea is normally slightly temporal to the anatomical center of the posterior pole of the eye. Now, there is another axis known as the anatomical axis or the orbital axis, which is a straight line passing through the nodal point and the anatomical center of the posterior pole. This is the orbital axis. So that is the two axes, visual and orbital. Now, normally, the orbital or the anatomical or the geometrical axis of the eyeball is not in line with the visual axis because the fovea is located temporal to its geometric center. This is the reason when a patient in the primary position and a patient is looking in the primary position and we shine a torchlight, the corneal reflex appears to be nasally decentered. Why? Because the fovea is temporal to the geometric center. So there is this little angle known as angle kappa between the anatomical axis and the visual axis, and that angle normally is 5 degrees. It is taken to be positive by convention, and that is why a slight appearance of exo is normal in all of us. Okay? Now, the lateral and the medial orbital walls are at an angle of 45 degrees with each other. Orbital axis therefore is at 23 degrees with both the walls, right? Medial wall, lateral wall. This is how the shape, this is the shape of the bony orbit, okay? And the eyeball is here, somewhere over here. So the orbital axis is at an angle of 23 degrees. This is the orbital axis. It's half of 45, so for convenience, we have taken 23 instead of 22.5. Okay, so when the eye is looking straight ahead, without any head tilt, without any face turn, without any chin lift whatsoever, that is the primary position. Okay, straight ahead as in looking at infinity. So the visual axis then is at 23 degrees to the orbital axis. Okay, this is the eye in the primary position, right? Looking straight ahead. So visual axis is at 23. We know that we have a little bit of exo, right? So this is the visual axis, 23 degrees. This is the orbital axis. Okay. Normally this 23-degree angle difference is there in all of our eyes when we are in the primary position, right? So the primary action of a muscle is the major effect when the eye is in primary position. This is the primary position. The primary position is when the eye is looking straight ahead and in which the visual axis is at 23 degrees to the orbital or anatomical or geometrical axis. Secondary position. Secondary actions or tertiary actions are additional effects of a muscle which depend on the position of the eye. For example, here the eye is in primary position. This is the line of pull of the superior rectus muscle. The eye is in primary position, looking straight ahead. This is the superior rectus muscle. So the primary action of a muscle, that is the superior rectus, in the primary position is elevation. We will see that in the subsequent slides. Now here they are actually trying to show the superior oblique muscle. We'll be discussing each of these in detail. So basically the diagram wants to show you that when the eye is adducted, that is, it is inside. Imagine the globe is rotated inwards. Then the line of the superior oblique muscle is in line with the visual axis. And so superior oblique is acting as a depressor. We're going to look at each of these in details. So let us first learn about the origin and insertion of these muscles. So we know that we have a pair of 6 extraocular muscles. So there are 4 recti. All of them originate from this annulus of Zinn, which is a tendinous ring at the orbital apex, right? annulus of Zinn, all the four recti travel forward and are inserted at variable distances from the limbus. Also, we have two oblique muscles, okay, which provide rotational movements. And this is the oblique, this is a superior oblique muscle, okay. It changes course at a bony pulley in the medial wall of the orbit, that is the trochlea, superior oblique, and inferiorly is the inferior oblique. The superior view and the temporal view of the eyeball, right? So 6 pairs of muscles, 4 recti, 2 obliques. Levator palpebrae superioris is also a part of the extraocular muscles, but then we will not be dealing about it in this particular series of lectures. Let us just talk about the muscles controlling the main extraocular movements, the recti and the obliques. Before we jump to the actions of the muscles, we have to know about the planes and axes of the eyeball. So imagine a coronal plane that is passing through the center of the rotation of the globe. That plane is known as listing plane. These words are important. Listing plane. Okay, this is the listing plane. Now the globe rotates on the axis of Fick, which intersect in the listing plane. Okay, so there are three axes, just like there are three dimensions, there are three axes, and the center of rotation of the eyeball is at the center of is at the point of intersection of these axes. So x-axis, about which the horizontal movements are happening, okay, upwards and downward movement. The y-axis or the anteroposterior axis, about which the rotational movements are happening, and the vertical axis or the z-axis, about which the horizontal left-right movements are happening. Okay, I think this is self-explanatory. So let us move on. Now, the horizontal recti. The horizontal recti means the medial and the lateral recti. They are the simplest muscles of the eyeball. They have just one action, that is adduction or inward movement in a horizontal plane. What is the plane of action, or what is the axis? The z-axis is the axis about which these muscles act. Left-right movements of the eyeball, your medial and lateral recti are at work, right? Origin is at the annulus of Zinn. Insertion, these values you have to remember. There is a mnemonic for this, MILS, and it is in that order. So 5.5, 5.9, 6.9, and 7, so on. So this is the primary position, okay? Lateral rectus, medial rectus. Only one movement, adduction or abduction in the z-axis. Very simple to understand, no rotation, nothing, okay? Now comes the vertical recti. The vertical recti are the superior and the inferior recti. Now these muscles are not so simple. Origin is the simple. It is from the annulus of Zinn, and the insertion is 7.7. This one 7.7. This one is 6.5. Now, what is the axis of action of these muscles? It is this axis, that is the x-axis. Okay, the horizontal x-axis. The movement is vertical, so naturally it will be about the horizontal x-axis. Okay. So primary action of a muscle, as we saw, is the main action of the muscle when the eye is in primary position. This position is the primary position. This is your line of pull of superior rectus muscle. Please remember, understanding any action depends a lot on the relation between the line of pull of a muscle and the visual axis. The orbital axis. So this is the orbital axis. This is the line of pull of superior rectus muscle. Please remember this. Secondary and tertiary actions, even the primary action for that matter, this you'll be able to understand only if you keep this diagram in mind. Okay? Now let us begin. Remember this orbital wall. So medial orbital wall, lateral orbital wall, primary position. This is the line of action of the muscle. Okay. So what happens if the eye is abducted by 23 degrees? The line of pull of the rectus muscle, even be it superior or inferior, is coinciding with the orbital axis. I told you, remember the relation between the line of pull of muscle and the orbital axis. So when the eye is abducted by 23 degrees or simply abducted, the line of action of superior rectus is coinciding with the orbital axis. When this happens, movement occurs only in one dimension, either elevation if the superior rectus and depression if the inferior rectus. So, this is the optimal position for testing the function of the superior rectus muscle because in the abducted position, the superior and the inferior recti are parallel to the orbital axis and they act purely as elevator or depressor. So, optimal position for testing the function of superior inferior recti is abducted. Okay? Now, what happens if the eyeball is turned inwards or adducted by about 57 degrees? Or simply remember what happens when the eyeball is adducted. When the eyeball is adducted, the line of action of superior rectus or inferior rectus is now perpendicular to the orbital axis, such that the angle between them is 90 degrees. Whenever this happens, whenever the angle between the line of action of the muscle and the orbital axis is 90 degrees, then a rotational movement happens. This is true for the vertical recti as well as for the oblique muscles. We will see how. And this is because the answer lies in physics. That is, the vector that results because of these two forces is in this direction or a rotational direction. Okay, this is simple physics. So in this position, only rotational movement of the superior rectus will happen. And since the superior rectus is attached on the top of the globe, it will cause an inward rotation. And since the inferior rectus is attached below, it will cause an outward rotation. So uh, intorsion and extorsion action of the recti muscles are seen in the adducted position. Okay, so I've explained the primary action, I've explained the tertiary action. Now the secondary action of the recti is adduction. Why? This is a very simple reason, because the muscle belly is traveling from medial to lateral, right? The pull of the muscle is medially, right? The pull is towards the orbital apex, right? That is the origin. So the pull of the muscle is medially. That is why the secondary action is adduction. So that's the vertical recti, superior and inferior rectus. There is also a mnemonic in case in the exam hall, if you forget all these complicated phenomena, you can just remember SINRAD, where superiors are intorters and recti are adductors. Okay. So remember sin and rad, and the opposite of this is also true. Superiors are intorters, so inferiors are extorters. Recti are adductors, so obliques are abductors. Okay. So let us, oh yes, of course, the spiral of Tilloch's. So the recti muscles, the horizontal and the vertical recti, are arranged in such a way around the limbus, or rather inserted at such a way around the limbus that a spiral is formed. Okay. So this is your mnemonic over here, MILS or mills, and the insertions are in the increasing order: 5.5 mm, 6.5 mm, 6.9 mm, and 7.7 mm. So that's your mnemonic over there, and that's the spiral of Tilloch's. Now, oblique muscles or the cyclovertical muscles, these are the most complicated muscles. So here we have to understand how the muscle is traveling as well, not just the origin and the insertion. So origin of the superior oblique is here, medial to the optic foramen from the greater wing of the sphenoid. This is your greater wing of the sphenoid. This is where the superior oblique originates. So the belly of the muscle travels forward parallel to the medial orbital wall until it reaches a bony pulley known as the trochlea. There suddenly it reflects backwards, it fans out and inserts here. in this way, in an arc on the posterior posterior upper temporal quadrant of the globe. Posterior, outer or upper temporal quadrant, posteriorly and outwards. Okay, coming like this, getting reflected and attaching posteriorly and outwards. That's your superior rectus. Sorry, superior oblique, right? So these are the anterior fibers and these are the posterior fibers. Anterior, posterior fibers. Okay. Although the muscle acts as a single unit, it is made up of two subunits. Okay. Inferior oblique, similarly, you'll understand it better here. It also travels medial to lateral, but it is like this. The origin is from the medial orbital wall, just like the superior oblique. Its origin is also from the medial orbital wall, but below orbital floor, maxilla, lateral to the lacrimal sac. So it is near the floor, okay, originating medially, traveling outwards and laterally, and inserting where into the posterior lower temporal quadrant of the globe, close to the macula. Now this is an MCQ. This is a very favorite MCQ. Which muscle is inserted close to the macula? So this is the insertion of the inferior oblique over here. This is the superior oblique over here, right? So both of them travel medial to lateral aspect of the orbit. Okay. Now, the primary action of superior oblique is intorsion. The secondary action is depression. The tertiary action is abduction. We are going to understand each of these actions in detail in the subsequent slides. So this diagram is just to, show the relationship of the superior and the inferior oblique. So this is the left eye, because here you can see the pulley, and this is the medial wall, right? So this is the patient's left eye as seen from behind. So this is the superior oblique, right? Inserting on the upper outer posterior quadrant of the globe. And this is the inferior rectus coming from the coming from the maxilla or the orbital floor and inserting close to it here in the macula. So they insert in an arc. All these muscles insert in an arc like this. Okay, superior oblique, inferior obliques, right? This is the relationship of the two muscles. Now, understanding the superior oblique action. So this is the muscle over here, right? This is the superior oblique muscle. I've highlighted it for you. Now, these are the anterior fibers and these are the posterior fibers. Now, suppose the globe is adducted or inward, rotated inward, but not rotated, rather pointing inward by 51 degrees. The visual axis is going to coincide with the pull of the muscle, right? We are talking about the anterior fibers. The anterior fibers, these are the anterior fibers which appear after the pulley. So now this part of the superior oblique muscle is parallel to the axis of the medially rotated eyeball or the orbital axis, and only depression is going to happen or elevation is going to happen in case of inferior oblique, right? Because the line of pull of muscle is parallel to the orbital axis in the adducted position. So superior oblique acts as a pure depressor. Why depressor? Because it is attached to the top of the globe. Similarly, inferior oblique acts as a pure elevator in adduction. Why elevator? Because it is attached to the bottom of the globe, right? So, the best position for testing the action of the superior oblique muscle is adducted position, because we have isolated the elevation and depression action of this muscle in this position. It is acting as a pure elevator or depressor in this position. The intorsion and the abduction actions are not there. So when you are able to isolate just one particular function of a muscle, then obviously that position is the best position to test the action of that muscle. So the best position for testing the action of the superior oblique is adduction, okay, or medially rotated eyeball. Now, when the line of action of muscle and the globe form an angle of 90 degrees, then rotatory movements happen. We have already discussed that. So when the eye is abducted or looking outwards, then the angle between the orbital and the line of pull of muscle is 90 degrees. So then it acts as a pure intortor, right? This position or the abducted position. Intortor for the superior oblique, extortor for the inferior oblique, right? So that is how the superior oblique muscle works. Elevation, depression, intorsion, extorsion. And since these muscles are, the pull of the muscle is this way, they are abductors. Okay, that abduction is the tertiary action. Remember the innervation. This is the mnemonic for the innervation. SO4LR6, that is superior oblique is by the fourth nerve, lateral rectus is by the sixth nerve, and all the remaining ones are by the third cranial nerve. Okay. This diagram, if you look at the globe from the temporal aspect, it is showing the relation between the superior oblique and the superior rectus. So the superior rectus is traveling from posterior to anterior like this. Imagine you are looking from the temporal side, and the superior oblique has attached here. It is sort of perpendicular to the to the axis of the superior rectus muscle, and it has come from the medial wall and attached here on the temporal aspect of the globe. Okay, so the artery forceps has gone under the superior oblique, right? This is a surgical view. So I think the movement of the extraocular muscles we're going to discuss in the subsequent lecture. So the first half of the lecture is there on the on my YouTube channel, my Opthal Teacher, and you can always revise it. And thank you for listening.